Good evening, everybody. We'll start. Good evening, everybody. We'll start the ward rounds for today. Okay, go ahead, Ainas.
Yes, sir. The first case, a 71-year-old female came with complaints of abdominal pain and rectal bleeding since 2 days. There were complaints of two episodes of blood mixed with stools 2 days back, and complaints of severe lower abdomen pain since the last 2 days, which was sudden in onset, non-radiating, moderate to severe in intensity, and not relieving with medications. Apart from this, no complaints of fever, vomiting, or altered bladder habits. The patient is a known case of COPD and hypothyroidism on treatment. Status post 2 LSCS, wherein copper T insertion was done after the first LSCS, and she conceived like the second LSCS was done while the copper T was in situ, and status post pulmonary valvulectomy. On examination, she was vitally stable and yes, sir.
Uh, who all has joined because I can't see here.
Einass, that history is not clear.
Yeah,
You
yeah.
said she conceived in spite of copper T. What had happened to copper T then?
Uh, sir, the copper T was still in situ, sir. Like during the second LSCS, the copper T was still there. Like it had,
Copper T was in situ or they were not able to see it?
it had, they were, like I thought I'll tell it in the CT findings, sir, that it had actually migrated to
No,
the,
no, no. That migrated is now. They got to know now. At
yes,
that
sir.
time, they could not find the copper T because
Yes, sir.
usually they would have removed if they have done cesarean section and copper T was there.
Yes, sir. Like they were
Yeah.
not
So
able
that
to look.
history,
Yes,
yeah,
sir.
that history is the key. Okay.
Yes. I'll go ahead, sir.
Yes, yes.
On examination, her patient was vitally stable, and on per abdomen examination, there was tenderness which was noted over the left iliac fossa region. Apart from that, there was no distension, guarding, or rigidity. And on PR, there was no significant findings noted. These were the routine investigations which were done, which were all within normal limits. And the patient had come with the a CT done, which was done outside. The CT showed that there was a curvilinear metallic density, like a foreign body, which was seen in the sigmoid colon. There was superior wall thickness in the anterior portion of the sigmoid wall, with focal collection and air pockets with a possibility of localized perforation due to the foreign body. This it was
Before you went, sorry, Ainas, before you
yes,
went,
yes.
I wanted to know what are your clinical, suspicions? What are the things that you were thinking of when you saw somebody like her?
Sir, we could if a patient is come with left lower abdomen pain and bleeding PR, we can suspect it to be like diverticulitis, sir, left-sided, or
Not we can. See, the thing you have to modify your listen. You should not say we can. So you
yes,
are
sir.
actually, we are asking you, so you should say, I will suspect.
Yes,
What are things?
sir,
Yeah,
I will suspect maybe left
71
side.
years.
Uh,
71 years of age,
uh,
left-sided abdominal pain. She has any bowel habit, change in bowel habits?
Bleeding PR, sir. The two episodes of bleeding PR. So malignancy could be with her age. Malignancy can be
Aina,
one. Yes, sir.
see, please understand to answer the question in the way it is asked. Is bleeding PR a change of bowel habits?
No, sir. No, sir.
Then I asked you, was there any change of bowel habits? So you
No,
should
sir.
say whether she was constipated, whether there was diarrhea, whether there was alternating constipation or diarrhea associated with abdominal distension or pain. So these things, you should, bleeding PR, yes, agreed, but
Yes,
left-sided
sir.
abdominal pain, any change in bowel habits?
No, sir. No change in bowel habits.
Okay. So
Yes,
at
sir.
71 years of age, what are the things that you suspect?
Sir, malignancy is one
First,
thing.
malignancy has to be first. Why
Uh,
why malignancy first but not diverticular disease?
uh, So it is based on the age, sir. Like
No, not based on the age. Even it's 51, 71 is a correct age for diverticular disease as well.
uh,
Anybody else?
Einass, what is the history here? Is it chronic or is it acute? So based
uh,
on that, you tell your differential diagnosis. First differential, second differential.
so this as of now, it is an acute history, sir. Uh,
Hmm.
so
So
like
you
they
categorize why you are struggling. So what is the history? What are the symptoms? How long it has been? Any danger symptoms?
so the history is only for 2 days, sir. But apart from that, the patient has not come with any signs like
No,
uh,
don't describe what sir is asking. What I'm asking is you have the
yes,
history. So based
yes, sir.
on that history, what is the differential diagnosis? So will be the usual history in malignancy? What will be the usual history in diverticular disease?
So in case of a malignancy, the patient will have other symptoms as well. Like it could be it will be a chronic history. Firstly, the patient can present with anemia. There can be loss of weight, loss of appetite as
No,
well. So,
wait. Anemia will be presented in what side malignancy? Right side or left side?
so more on the right side, sir.
Ah.
Then why did
Yes,
you say
sir.
anemia?
Mm, yes.
So what is the
See,
more commonest presentation in left side malignancy?
Uh,
How
abdominal
do they present?
distension, change in bowel
Obstruction,
habit.
usually
uh,
features
uh,
of obstruction and change in bowel habits,
yes, sir.
alternating the constipation and diarrhea. Maybe occasional bleeding,
Yes, sir.
And they'll complain initially. They will have bloating sensation, difficulty in
bloating,
passing
yeah.
motion, which keeps getting worse and worse.
And also maybe history of weight loss if it is chronic.
Right? Yeah. Diverticular
So
disease.
in
What will be the features? Diverticular disease.
So in diverticulitis, like the patient can come again with abdominal pain. The patient can also have fever, sir, and uh, uh, bleeding PR is also a presentation of diverticulitis, sir.
Okay. Chronic
so what
constipation.
And
hmm.
yes, sir.
So what do you think in this case? Which to which this thing it matches that malignancy or diverticulitis?
So more towards diverticulitis, sir.
Correct.
Yes, sir.
So because it is acute, only 2 days history, pain abdomen, and then there is bleeding PR. So there is no chronic history of any bowel or bladder bowel disturbances, and also no danger symptoms. So most likely first differential diverticulitis or diverticular disease, or some second this thing will be anyway in elderly you cannot 100% rule out malignancy till you evaluate.
Mm. Yes, sir.
So you should have a very. It's one Karthik. Karthik there?
Sir, I'm here, sir.
Yeah. What other differential diagnosis will you entertain apart from these two?
Uh, apart from this,
Left-sided abdominal pain and bleeding.
uh, tumor. Any stricture, sir?
Why stricture? Why suddenly you gone to stricture? She doesn't complain of any distension or abdominal
Yes,
bloating
sir.
or vomiting or anything.
She
You
has
should.
a cardiac history also. So in elderly, what is the other possibility in colon or anywhere else?
Cardiac
Uh,
history, ischemic bowel,
Yes, sir.
mesenteric
Ischemic
stem.
colitis.
Ischemic. Okay.
ischemic bowel, left-sided abdominal pain, bleeding. Ischemic colitis has to be considered. If there was not much pain, then and just bleeding, you should consider angiodysplasia, especially if they have cardiac illness, especially aortic stenosis and things like that. They will have the angiodysplasia. And a very, though the cases, number of cases are rising, the second peak of inflammatory bowel disease in the seventh decade. So you should think about that also, but that should come very low in the priority list. So as Niranjan said, diverticular disease because of the explanation he has given, then malignancy, then ischemic bowel, ischemic colitis. So these are the three important differential diagnoses you should think of. Okay, now go for the investigation. So don't jump into investigation straight away. Einass, okay, go on.
So the investigations done were the routine investigations, which were all within normal limits, and
Okay.
the CT abdomen and pelvis, which was done. The patient came after getting a CT done. This showed that there was a curvilinear metallic density for foreign body, which was seen in the sigmoid
Anas,
colon.
did you tell the clinical findings?
Yes, sir.
What were the abdominal findings?
Sir, there
You
was
didn't.
tenderness which was present over the left iliac fossa region, sir. And
No,
there
was it very severe tenderness? I don't think. Abdomen
no,
was
sir,
soft,
no,
very
sir, not
mild
very
tenderness.
severe, not severe, sir.
So who will mention that? So that is significant, no, clinically. Was there
PR,
any
PR,
signs of peritonitis?
No, no, sir. There was on per abdomen examination, there only mild tenderness was elicited on in the LIF region. There was no distension, guarding, or rigidity noted, sir. No, and on
PR?
PR, there was no significant finding noted on PR as well, sir.
Yeah, so that is important, no? So
Uh,
clinically, before you go on to go on to describe the investigations. Yeah, tell.
okay.
Yes, sir. After this routine investigations, which were within normal limits, CT abdomen, which showed a metallic density body in the sigmoid colon, and superior wall thickness, which was noted in the anterior sigmoid wall, and with focal collection and air pockets, which were seen, which suggested of a possibility of localized perforation. Uh,
Sealed of perforation.
uh,
Probable sealed of perforation.
yes. So after this, there is the colonoscopy findings, sir. Should I go to that?
So based
So what
on
did you think?
Uh, so like a foreign body, uh, copper T, which is like basically migrated from the uterus to the sigmoid colon, maybe through a fistulous tract formation, sir, is and which has caused these features, sir.
okay, because that can be the only possibility. She has not had any other instrumentation or anything like that. No, so this is the only one. So that has to be the only differential diagnosis.
So there are two scenarios here. If patient had signs of peritonitis and there was active contrast leak, what you would have done? And in this scenario, what you will do? Forget the investigations, forget the management, what we did. So these are the two scenarios.
So if
It could
there
have
is
been it could have been a peritonitis picture with leak from the contrast leak from the this one and patient being sick.
so if the
So
if
this,
it is
Aina, is this property lying outside the lumen of the sigmoid colon, or is it in the wall and then also in the lumen?
sir, in the adherent to the wall and in the lumen, sir.
So it is
Yes,
not extraluminal.
it is not extraluminal. No, sir.
Okay. So in that scenario, as Niranjan said, perforation, patient has got evidence of peritonitis. What will you do? And if it is not peritonitis, if the patient is relatively stable, there is no leakage of contrast, just localized collection, what will you do?
So if it is a case of peritonitis, like after stabilizing the patient, we will consider taking her up for an emergency uh, uh, exploratory laparotomy, sir, to localize the site of perforation to contain the peritonitis and like find the foreign body, followed by like resecting the portion which is perforated, sir.
Why you have to
Uh,
resect? Why not laparoscopy, diagnostic
Ah,
laparoscopy? Why
uh,
you have to resect?
sir,
why not diagnostic laparoscopy?
so will
You,
with
you can do a diagnostic laparoscopy. Karthik, what will you do if you do a diagnostic laparoscopy? You opted to do a diagnostic laparoscopy. What will you do?
In the diagnosis, we will just check for the bowels, or where is a perforation, and we'll just check where is a leak is happening, and We'll give a thorough wash and we'll localize the perforation site, sir, in that.
Okay, then what will you do? You localize the perforation.
Yes, sir.
What will you do with the copper T? What will you do to the perforation?
If the copper T is extraluminal, then we will extract the copper T, sir, from the laparoscopically, and we will do the primary repair, sir, of the perforation.
That depends. What does it depend on? If you want to do a primary repair,
It depends on the how big is the perforation, sir. If the perforation
one
is so
is size. Yeah, one is size of the perforation. Correct.
size of the perforation, and
Then,
if
No,
any
more important than the size of perforation. What is
yes.
important to
What is more
decide whether
important?
you primarily close or whether you will do something else along with the closure?
if it is infected and there is a signs of inflammation, we will do
No, there will
yes,
always be
sir.
signs of inflammation and signs of infection.
Yes, sir.
So
The
what
status of the bowel. Is the bowel
Gangrene.
healthy or unhealthy? Is the
Okay,
bowel
sir.
very friable and inflamed? Is there
Yes,
a
sir.
and is it only localized
contamination?
collection or if there is gross peritonitis?
Yes.
If
Fecal
there is localized
peritonitis?
collection,
Yes,
if there is
go ahead.
localized collection, what you will do? If there is gross peritonitis, what you will do?
Anyone can answer. Nikita, you are silent.
Sir, if there is localized collection, we'll give a wash, clear it off, and see the size of the perforation. And if the
Ah,
ends are healthy, we can go for an closure of the perforation and, if possible, a patch of the omentum on it, sir. Otherwise, if it is a gross contamination, an unhealthy bowel, it's better we plan for an temporary end colostomy or loop colostomy, sir, in that case, or resection anastomosis if it is feasible.
see, if it is gross peritonitis, it is better not to consider. I don't think you should answer in the exams that you will do a primary resection anastomosis. If there is gross contamination, one is the patient's general condition will not be good. Two, you cannot take too much of time in a especially 71-year-old patient. Three, if you are doing an anastomosis in the environment of a gross peritonitis, then the post-operative recovery will be very stormy. The anastomotic leak chances are high in those situations. So, if what you said about the localized perforation, drainage and irrigation and lavage and primary closure is acceptable. But if there is gross contamination, fecal contamination and things like that, I would say what you said first. There is to resect that segment of the bowel and bring it out as a stoma. That would be more acceptable.
What is it called as, Nikita? You resect and bring
Hartmann's
out a
procedure, sir.
yes.
Yes, Hartmann's procedure. But other thing is, if for example there is bowel looks unhealthy, but there is no gross contamination, then as you can consider doing a resection of that segment anastomosing, but giving a backup loop colostomy or an ileostomy.
Yes, sir.
So it depends on the situation of the inside the abdomen. So one is, as Niranjan said, the condition of the bowel, how healthy or unhealthy it is. And then how much of contamination is there? Is it just pus localized collection or is it fecal contamination? All these things matter. Okay, the other thing is other scenario which Niranjan said. If the patient is relatively well, there is no evidence of local peritonitis or anything, what will you do?
Like in this case,
Einass,
Right. So
what are the options?
we can attempt for like a colonoscopic retrieval, sir, of the foreign body.
okay,
Uh,
then
uh,
So
uh, yes,
if you attempt that, what you should be ready for?
the chances of that after dislodging of the foreign body, the perforation happening, sir, at the uh, wherever the foreign body is dislodged, there's a
there
chance
is
of
already perforation, ma, because if
There,
in
there,
this
there
one,
is there is already a shield of perforation. So it
Yes,
might
sir.
open up. So what you should be ready if they are not able to manage it through colonoscopy.
Uh,
If they are able to see the perforation through colonoscopy, what are the options?
uh, so
What are the
like
colonoscopic options? What are the surgical options if they can't manage it through colonoscopy? They have removed the copper T and there is a hole there.
so
So what will you do?
like sir, we can so clips can be used, sir. Like if at all the perforation is small, sir.
It's called
Yes.
OSCO clip.
OSCO
OSCO
clips.
Yes.
clip.
Oh, yes, sir.
So what it does is basically you suck the whole, the bowel into
Tissue
the thing, and then you
like a
apply
band.
the like a band. So it closes the perforation completely. Or you can use multiple clips if it is a linear kind of perforation,
Yes, sir.
approximating the approximating the ends. You can also
Suppose
use
they are,
glue.
yeah. Suppose they are not able to manage that, then they have
Uh,
retrieved the foreign body. Perforation is there, but they are not able to approximate it.
so then immediate surgical intervention, sir. Like uh, we go ahead first laparoscopically, sir, and uh, try for to approximate the perforation, sir.
Yes,
Uh,
correct. Since there is no gross collection, you can approach it through laparoscopy. If you are well versed with laparoscopic suturing, you can manage if it is a small perforation, or you do a laparotomy.
yes.
Okay. Now, um, Nikita, Nikita,
Yes, sir. Yes, sir.
yeah. Now you have done the second thing. What Niranjan just said. You have retrieved the foreign body, and you have closed the, laparoscopically closed the perforation. Now describe what are the things that you will monitor with this patient post-operatively, and what are the possible complications that you expect?
Uh, so procedure related complications, we would be expecting the non-approximation of the perforation, sir. So there is a chance of mm dehiscence of the wound, resulting in abdominal distension or contamination and peritonitis. So
No,
we'll be monitoring the abdomen.
what are the first signs of leak? In other words, that is what sir is asking. First thing which you are worried about that is leak.
Yes, sir.
So what are the primary signs of leak? Abdominal distension comes later.
Clinically, yes, sir. Tachycardia and fever should be presenting with.
Yes.
Patient will usually with these kind of things they will not pass flatus, or they will not pass motions. So there will be ileus initially, and as you said, there may be fever, there may be tachycardia, there may be tachypnea. So there, the general, deterioration of general condition.
Yes, sir.
Patient looks ill, and then, as I said, later distension will become apparent.
Yes, sir.
Initially, there will be ileus. Normally, you would expect, smooth recovery within or 24, 48 hours, maximum
Okay.
72 hours, the patient to have passed flatus and maybe even moved the bowels and things like that. If they haven't done, and if the abdomen is silent and it's not, there is ileus, then you have to get worried about it. And later, the ileus will turn into distension. Anything else, Ainas?
Uh, no, sir.
So what
What
was
will
done?
happen to you?
Yes, sir.
What will happen to urine output?
So it will
Will
decrease. Uh, like not initially, sir, but over a period of time, like we'll note a decrease in the urine output, sir. Uh,
So that's one of the first
uh,
signs that things are not progressing accordingly, according to your, to the normal post-op recovery.
Yes.
Nikita, there is one more scenario. There is you have done a check radiological evaluation, rectal contrast with CT or oral contrast with CT, and there is a tiny leak from the sutured area, but patient is clinically completely stable. So how will you manage that case?
Sir,
And
if
also,
patient is
also give us the rates of radiological leaks in comparison to clinical this thing. What is the percentage?
What is the percentage of clinical leaks?
so clinical leak is up clinically up to 30%, sir. I'm not
Oh
sure
my God.
exactly.
No, no, don't go there. Praveen, what is the clinical leak percentage, man? Praveen there or not? Hello?
Yes, sir.
Praveen?
Hello, sir. Sir, able to
What is
sir.
what is the
2 to
percentage of clinical
10%, sir.
leak? Huh?
2 to 10%, sir.
2 to 10 na?
Yes, sir.
2 is low. 2 is very low. 5% is usual. 5 to 10% maximum. What is the percentage of radiological leak, Nikita?
That would be high, sir. Probably up to 20 to 30%, sir.
I think about 30%, even up to 40% is accepted, but they are not clinically relevant.
Significant, yes, sir.
So how do you
So
manage them?
in that case, if the patient is clinically stable and the vitals are fine and the total counts are everything under control, we could wait and watch, sir. We could just keep NPO and observe the patient. If it is not progressing,
No, only NPO is
once,
sufficient. How do you handle the nutrition?
yes, parenteral nutrition, sir.
Yes, correct.
And once the patient passes flatus and stools, we can initiate the oral nutrition.
Not once, like how long do you have to wait at least for that this one to heal?
So, at least 48 hours, sir.
Will it heal in
Mucosa,
48 hours?
So we'll have to go to wound healing now.
sir,
So
if
how
it is a
long will it
complete
take?
fistulous tract, it will take approximately 2 to 3 weeks, sir. But in case if
You
it is
don't have
just
to
No,
wait
a
that long.
mucosal tear,
if it is complete, this thing patient will have peritonitis. That is what we are asking. No, radiological leak versus clinical leak. Radiological leak means it will be a tiny this thing. So
So you have
understand the
to
questions in
come
exam.
5 to
yes, sir.
7 days now. 5 to 7 days is usually what is required. By and large, 5 to 7 days, the radiologic leaks will all heal. So then you can gradually, start oral intake and, build up and taper off the TPN.
Yes, sir.
Other thing is, if the patient is diabetic or patient has high risk, then you may have to give IV antibiotics as well. Okay. Please move to the next case, Niranjan.
Sorry, let us show what happened in this case.
Yeah.
Colonoscopy.
Okay.
So in this course, the colonoscopic attempt was done, sir, wherein the copper T was retrieved completely, and after retrieval of the specimen, there was no the post uh, like colonoscopy, like after the retrieval of the foreign body, there was no perforation which was noted, only ulceration at the site of the of the lodged copper T specimen.
Okay.
Yes, sir. After this, the patient was
What was
kept.
the description? What was there? What was the report? What did they describe? Colonoscopy. So there was erythema. It was not completely, there was no perforation. It was erythema and ulceration at the site
Ulceration.
of impaction.
Yes, sir. Uh,
So what was done?
They retrieved that's what, sir. And biopsy was taken from the site of ulceration, sir. Uh, uh, After this, the patient was kept nil orally for the next 2 days, and TPN was started for her, and TPN and IV fluids were given. After this, after 48 hours,
Was TPN mandatory in this case?
uh, no, sir, because we are keeping her nil per oral for a long duration, sir. Like before the procedure
How
also.
long? How
No.
long do you or how for patient to like you have to if you have to start TPN for a patient, how long the patient should be on nil oral status?
Sir, 3 to 4 days, sir.
No.
No, at least 5 to 7 days. Anything beyond 1 week, if you're expecting, then you start off TPN.
Start treatment. Yeah.
So ideally, in this case, it was not required because, but since the medical gastroenterologist had advised, we went ahead with this advice. So ideally, in this scenario, you need not have to start TPN. You just could have kept 48 hours, nothing would have happened.
Yeah. Yeah.
Yes. Uh, the, like after this, after 48 hours, a repeat ultrasound scan was done to look for any localized collection. Since the post the scan, as there was no everything looked normal and there was no collection which was visualized, the patient was started on liquids initially and then escalated to soft diet. And
Einass,
yes, sir.
is ultrasound the right investigation to look for collections?
So CT will be more sensitive, sir, to visualize collections, sir.
See, ultrasound is good for subphrenic collections, in the gallbladder bed and under the liver, perinephric, and things like that. But pelvic and the inside in between bowel loops and things like that, it can, because the bowel gas will come in the way, so it may not be they may not be able to visualize any collections or leaks if there are any. So ultrasound is suboptimal in this situation. But you would do that anyway, because if it picks it up, then it is there. If it doesn't pick up, it still doesn't rule it out. You followed?
Yes, sir. Yes, sir.
Okay. Right.
So along with ultrasound, what was more important? Clinically,
The patient, there were no symptoms, like the symptoms had resolved, sir. Like there was no tenderness. She was tolerating orally. There were
no.
no,
Before tolerating allowing her orally, did she have any tachycardia? Did she have
no,
any
sir.
abdominal pain, tenderness, ileus, a kind of picture,
No,
or was there any fever spike? Nothing.
no, sir. No. She was vitally stable throughout, sir, and no signs of peritonitis were seen, sir.
Yes.
After which she was started orally, sir.
And follow
So, for like she was advised for a relook colonoscopy, sir. For which they
After 10 days.
after 10 days, sir.
Not yet. I don't think it's still
It's
done.
not done yet. Sir.
up. Okay.
Yes.
Right. Go on to the next case now.
Yes, sir.
Did you have a look into the literature review, Einass?
No, sir. I haven't.
Displaced copper T and presenting after so many years. It will be a
Other
very
thing
rare
is,
case of going to literature review,
I
so that you
think
can
this,
make it as a
this
poster.
can be a poster. This can be a poster. Other thing is, what is the incidence of pregnancy in patients who still have copper T in situ?
Yes,
You have to look into that also.
yes, sir.
Because she did have a second pregnancy despite copper T being there, right?
Yes, sir. Yes, sir.
Okay. So
Yeah, and they were not able to localize the copper T during delivery.
Yes, sir. I'll look into that, sir.
Second case.
Yes, sir.
Is Samir in wedding celebrations or is he joined? When is his wedding actually?
ಆಯ್ತು ಅನ್ಸುತ್ತೆ 25th or 26th.
Aita, okay. But Samir has not joined, no, obviously. Okay. Right. Aina, start the second case.
Yes, sir. In this, the second case, a 52-year-old female came with complaints of swelling over the supraumbilical region since 1 year. The swelling was insidious in onset and progressively increasing in size, and it was associated with complaints of pain since the last 2 days. The swelling was not reducing on lying down or on compression. Apart from this, she had complaints of difficulty in voiding since the last 3 days. There were no complaints of fever, vomiting, altered bowel habits, or chronic cough. She was a known case of hypertension, hypothyroidism, and recently diagnosed diabetes mellitus on treatment. And surgical history was that of bilateral total knee replacement surgery, which was done around 9 years ago. On examination, the patient was vitally stable. Per abdomen, there was a 6 x 6 centimeter swelling, which was noted over the umbilical region, wherein tenderness was present. The swelling was not reducible, and the contents were doughy in consistency. There was no overlying local rise of temperature or skin discoloration, which was noted on examination.
Any other mass felt?
No, sir.
What was the surgical history, Einass?
Only bilateral total knee replacement surgery was done, sir.
No, this one. No, male patient or female?
Female patient,
I
sir.
missed it. Female. So
Female.
no tubectomy also.
No, sir. No, sir.
Oh, supraumbilical. Okay. I thought supra. Okay.
Was there no fullness and tenderness in the suprapubic region as well?
Sir, not on the in the suprapubic region, sir. More over the supraumbilical region only, sir.
Yeah,
But she had primary complaint.
Hernia was not reducible. There was no cough impulse. It was tender. That
Yes,
was
sir.
agreed. But
Yes,
I
sir.
felt that there was also a suprapubic kind of fullness, though not definitive mass there.
Yes, sir. Primarily, like her complaints were that of difficulty in voiding, sir.
Passing urine. She could not void.
Yes.
Okay. Right. So, Karthik, how will you investigate this lady?
Sir, first we'll go with ultrasound abdomen and pelvis, sir, to check the hernia is obstructed in the state of obstruction or not. And as the patient tells with a history of urinary complaints, so we have to check for the bladder, any with post-void residues or any other things are there, sir, in the bladder.
Okay. Difficulty in passing urine, especially in women. In women, what are the likely causes for difficulty in passing urine? Nikita? Women of this age. Nikita, are you there?
The difficulty would be from routine causes. It would be urinary tract infections.
Okay.
And it could further go to if there is any prolapse, sir, like vaginal prolapse.
Prolapse,
that
correct.
also would be irritating, and some neurological conditions like bladder dysfunctions.
Okay, then. Can there be strictures of the urethra?
Yes, sir.
Stricture urethra, then what else? Then malignancy of the genitourinary tract.
Yes.
You can have CA cervix or whatever, which is causing infiltration. Okay. Einass, tell us the ultrasound findings.
Yes, sir. On ultrasound, it showed a supraumbilical region hernia with a defect of 4.5 centimeter and omentum as content. There was a bulky uterus with intramural anterior wall calcified fibroid, which was measuring around 8.2 to 6.8 centimeter, and this was displacing the endometrial cavity posteriorly.
Okay.
Uh,
So what will you do for this patient?
Because it's an obstructed hernia, sir, we'll go ahead with a surgical management, sir. Again, apart from this, she also has a bulk, like a huge uterine fibroid, sir. So we
Yeah.
would consider an open approach more feasible in comparison to the laparoscopic approach, sir, because of the size of the fibroid, sir.
Size of the uterus.
Yes, size of the uterus. So we would go basically umbilical hernia mesh repair along with a hysterectomy should be considered for this patient, sir.
What incision will you make?
Sir, midline incision, sir, to include the supraumbilical hernial region as well, sir, and the incision in extending from the supra-umbilical to the suprapubic region, sir, midline laparotomy incision.
Somebody suggested that you just do 2 incisions, fan and steel incision and then umbilical hernia, the incision over the umbilical hernia. Would you do that?
So it can be, so it won't be more feasible, sir. I'm not sure, sir, about that.
Karthik, will you consider doing, because anesthetic suggested that
Yes.
why don't you do two separate incisions? Why
Uh,
didn't we do that? Why didn't we do the 2 separate incisions?
Sir, one, it was in the emergency procedure. We have to go with a faster incision, sir. If we put a two incision, then we have to go with a
No,
one
but
after that.
why do you say it is emergency?
The patient was, the hernia was in the obstructed state, sir.
If your
So
momentum is content, how can it be
it,
obstructed? What do you call that?
it's a
What do you call that hernia?
Incarcerated.
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 Okay, so why not 2 incisions as the anesthetic suggested?
And why you have to do an hysterectomy? And do you do hernia repair with hysterectomy usually? And that too when you're suspecting incarceration. Or in an emergency, suppose bowel is there.
Nikita, Praveen, either of you.
What is the age?
50?
52.
55, no?
Okay.
52, yes, sir.
So is she menopausal, perimenopausal?
So she was
Is she having any
post-menopausal.
symptoms? Is she having any symptoms due to fibroid?
So the difficulty in voiding could be because of the fibroid compressing the bladder, sir. Because
But it is not given here, no? It is saying posteriorly it has displaced the uterus. So it has to be anteriorly displacing the bladder. You have not evaluated for other causes of this one. What is the most common in that age group? Sir was asking, no, for urinary symptoms.
No answers.
Anybody?
So,
Nikita, exam going.
Sir,
Praveen,
preferably if it is an obstructed hernia with bowel as content, and if you are if you're suspecting any contamination, we wouldn't be doing the hysterectomy, sir. But in this case,
You wouldn't even be doing mesh repair also
yes, sir.
Yeah.
if it is strangulation.
But as it was omentum, and mesh would be in a different plane because the recto
How will
rectus
it be in a
repair,
different plane?
ret- open repair, sir.
No, but when you're doing it through a same incision.
So, Karthik, why we did the midline
Yes, sir.
incision? Because
Yes, sir.
the thing is, the repair of the retrorectal repair would be much
Yes,
easier
sir.
if you do it through the midline incision.
Midline.
And this uterus was huge, and it was coming up almost up to the umbilicus anyway. So
Yes, sir.
there was doing a fan and steel would not help in any way. So we did a lower midline incision coming up to just above the suprapubic region, and we were able to access both the hernia and the uterus.
Uterus.
And the uterus, actually, though they had said it is falling backwards, it was actually pressing onto the bladder. In fact, it was stuck to the bladder in one place. So
Yes, sir.
that is probably the reason she was unable to pass urine easily, and that was her main complaint. So for that reason, we did a hysterectomy and Reeves Stopa repair. And the omentum was healthy. It was just it was stuck, as you said, incarcerated. There were multiple additions of the omentum, the omentum onto the sac. And once we dissected all of that, the omentum was healthy. So there was no need to even resect the omentum. So which is why we went ahead with the repair. And so we also, excised the sac completely and then did the Reeves Stopa repair, retrorectus mesh repair. So what are the problems that you anticipate in somebody like her in post-operatively, Nikita?
Sir,
Because
first and
it's a
foremost thing would
huge
be bleeding, sir, hemorrhage, because
hemorrhage.
we did
Yeah,
hysterectomy
hemorrhage, yes.
and mesh infection in the later stages, sir, not immediately, but because of the genitourinary tract has been, sir.
What did you say, second complication?
Sir, mesh infection on a later date in case because of the
Why mesh
vaginal vault
infection?
has been opened.
Wound
Vaginal
infection.
vault was not open.
Sir, for hysterectomy, we would have exposed
We just clamped the thing lower end and sutured it, and before he took the clamp off.
Yes. Mm.
So there was no major, exposure of the thing. But potentially
Wound infection can happen.
Wound infection, mesh infection can happen.
Mesh infection. Yes, sir. And routine of hernia like seroma formation and recurrence.
Correct.
And
Hematoma, because retrorectus, dissection, you can get post-op, that is another significant complication. Hematoma in the the retrorectal plane. Because we create that plane, and usually we avoid injuring the vessels, but sometimes there can be inadvertent injury which we had not recognized, and then there can be hematoma.
yes, sir.
Ileus, post-operative ileus is another complication. Urinary tract infection.
Infections.
And inadvertent injury to the bladder. Sometimes inadvertent injury to the ureters also, because the uterus is huge, and you by ligating the uterine arteries, you may injure the ureters. So these are the things you have to be careful about. Einass, tell us about the post-operative recovery.
So the in the post-operative recovery, the patient was hemodynamically stable throughout. After which, she was started orally on clear liquids and liquids on post-op day 0 and post-op day 1 and 2. After uh, she mobilized and she was passing a flatus from post-op day 2 onwards, and that is when the diet was escalated to soft diet. Throughout the period, there was on examination, the abdomen was soft, there was no distension, and apart from that, the urine output was also adequate, and there was no evidence of hematuria which was noted. And after which, patient was discharged on post-op day 4, sir, once she was tolerating soft diet and passing stools and mobilizing well.
Okay. Any questions? Any comments, complications, problems?
Was the patient obese, Einass?
Yes, sir.
So what is the role of drain placement? And if at all, if you place a drain, where do you place it?
Sir, the drain, like you, if at all there's during hysterectomy, if we come across a lot of bleeding, that is when we consider placing an abdominal drain, sir. Otherwise, because of the obesity, we can place a drain in the subcutaneous plane, sir, to reduce the discharge.
Not in the subcutaneous plane. Subcutaneous plane is okay, I agree, if it is
Yes,
too
sir.
large
Oh,
panicula's.
yes, sir.
But since you have opened up the incision from where to where?
From the supraumbilical to the suprapubic region, sir.
Yeah. So there is a large space there.
Yes, sir.
So if you feel that there is a possibility of seroma, you can keep a drain in the retrorectus plane
Yes.
for temporary this thing.
Karthik, what is the other complication? Niranjan just asked now.
Yes, sir.
Is the patient obese? What is the other complication you would expect in this lady?
So the other is a deep vein thrombosis, sir.
Correct.
As
So what did we do?
obesity, sir, we usually start on the low molecular weight heparins and ask. Initially, we ask the patient to actively mobilize, sir. Then, along with that, we add a pharmacological low molecular weight heparin to prevent the DVT, sir.
What did you do for this patient?
So we actively mobilized the patient with the help of a physiotherapy, and we also started on the low molecular weight heparin, sir.
She was on floatron boots for 24
Flotron.
hours.
Yes.
Yes, sir.
And
Yes,
then
sir.
she was on TED stockings,
Yes, sir.
mobilization, and heparin.
Yes,
Because
sir.
she's obese, pelvic surgery, both are high risk for deep vein
Deep vein, sir.
thrombosis.
Yes.
Okay. Okay. So I think these two cases we have done. Niranjan, two cases ಸಾಕ ಇನ್ನೊಂದು ಮಾಡೋಣ ಅಷ್ಟು quick ಆಗಿ.
ಆಯ್ತು ಸರ್, ಕ್ವಿಕ್ ಆಗಿ ಮಾಡೋದಿದ್ರೆ ಮಾಡ್ಬೋದು. But
yeah, what case we have, ma? Third one.
The one doubt I had.
Ah.
Sir, in case of a retrorectus hematoma in the same plane, we have kept mesh. Suppose we try to manage that conservatively, but we are not able to manage that conservatively, only think about surgery and evacuation of hematoma. When should we consider removing the mesh, or can we leave the mesh and just evacuate hematoma, sir? If the hematoma is big.
You answer the question. You answer the question because you heard Dr. Lakshman talk about this very, extensively. So you answer the question.
Yes, sir. I was thinking we can just evacuate the hematoma and come if there are no other signs of infection, or if the patient is not at risk of infection.
So first of all, you don't even need to evacuate the hematoma. Maybe if it is not expanding, just observe it for a period of time.
That's what, sir. If you're not able to manage conservatively and we plan for a surgical evacuation,
then
if it
you
is in
can
the same...
first consider asking radiologically, see if they can evacuate the hematoma.
Yes,
and
sir.
Maybe even place a drain to
Yes, sir.
to drain it off. So that is the first line of treatment. Sorry. If radiologically you are not able to do it, then consider doing it surgically. but you don't have to explant the mesh, because even with mesh infection, the explantation rate is only 20-30%. So with mesh infection also you can manage it, without explanting the mesh. So definitely with hematoma, you don't even have to consider explanting it at all. You can just
evacuate
evacuate the
hematoma and
hematoma, wash it,
okay.
put a drain and come out, and
Okay.
remove the drain as and when. Maybe you will have to cover, because there is mesh and you are putting a drain. So what is something from inside can come out, something from outside can go in as well. So
Yes,
just cover that time when the drain is in place with antibiotics. That is all you need to
okay.
do.
And
Yes,
you can go in extraperitoneally also, TEP plane. Since you've
yes, sir.
already finished the laparotomy, you don't you can put in a laparoscope, wash out, and keep a drain and come out.
Yeah.
No, sir, but how will we extraperitoneum into the retrorectus plane?
Yeah.
Yes, yes.
Okay, sir.
You open the
Okay.
anterior rectus sheath, how you do TEP,
Yes, yes, sir.
E-TEP.
Yes,
Yeah.
yes, sir. Yes, sir. Okay, okay.
You don't have to go in again, do a
Do the
laparotomy.
entire laparotomy. Got it.
You will avoid a laparotomy.
Yes, sir. Yes, sir.
10 ಆಯ್ತಲ್ವಾ?
10 ಆಯ್ತು.
Okay. Any questions, any doubts in the two cases we discussed? Praveen, Karthik, Likith, you've been silent, totally silent. Hello? Likith, are you there?
He's there, sir. He has joined.
He's not answering.
Hello.
He's not even saying yes that I'm there. Forget about asking questions. Okay. If there are no questions, thank you, Niranjan. Thanks everybody for a good discussion. Good night.
Thank you, sir.
Thank you,
Thank you,
sir.
sir. Thank you, sir.